We move on to the next case. This will be presented by Dr.Senthilnathan. Welcome you here, sir. I think from GEM Hospital. Move on to the second case.
Good evening to all. This is my first visit to Chennai Pancreas Club. Special thanks to Patta sir for inviting me.
Because during the early session you were not in Chennai.
Right, sir, right. A couple of cases for us to discuss. The comments are always welcome. This is a 54-year-old female who has got a epigastric pain for 6 months with a history of weight loss. On investigations, examination vital stable, no mass palpable. Investigations by and large normal, including the OGD. Tumor markers, again, both AFP and CA were normal. But CA abdomen showed tumor in the caudate lobe with a delayed phase, washout in the portal venous phase and delayed phase in the caudate lobe. It's about 5 centimeters, and the pre-op diagnosis was the hepatocellular carcinoma. This is the tumor. Just coming to the scenography. Here you can see nicely enhancing lesion situated in the caudate lobe. Center, huh? Oh, okay. So you can see nice. Now it's getting washed out. This is the delayed phase. It's completely off the contrast. The portal vein, this is the portal venous phase. You can see nicely the portal vein. So here we have a caudate lobe tumor. It's about 5 centimeter and about washout both in delayed phase and in the portal venous phase. So, and the PET scan showed again a 5 centimeter heterogeneously enhancing lesion and diffusion restriction on MRI screening as well, because we wanted to make sure that what's the diagnosis without putting the needle on. And again, further evaluation also zeroed in that we are dealing with a low grade HCC and no evidence of distant metastasis as well. So here we have a patient, a lady who has got a probable hepatocellular carcinoma of the caudate lobe of the liver, planned laparoscopic caudate lobe resection. Any clarifications till now before I move further?
You said FDG it was positive.
Yes, sir.
Usually for a HCC, general recommendation is not to go for a FDG PET scan. It's not a very sensitive investigation.
Yes. So initially, we have a tumor, we wanted to characterize more. We have ordered for a MRI. So obviously, when the first diagnostic modality we CT, we go for MR. And here, even in MR, we had a doubt. So again, we have combined with PET CT to have more clarification on that one. Putting a needle in, that too in caudate lobe is slightly risky. So we went ahead for HCC. Of course, I do agree. PET sometimes do give more confusion rather than have more clarity on that one. So,
what is the need for PET? I think two imaging modalities are good enough to think of a HCC and go ahead.
Because you had a very classical radiological evidence of HCC, enhancing tumor in the arterial phase and washout in the venous phase. That's very classical of HCC.
Yes, sir.
Only thing is alpha fetoprotein is not elevated.
Not elevated,
Which can happen in 20% of the patients.
Yeah, definitely. Well differentiated. Sometimes you can have that one.
Viral markers were negative.
Sir?
Viral markers were negative.
Negative, sir.
Yes. Sarunan, you have any comment on this? Bhaskaran, welcome.
There are institutes which have PET-CT as a routine part of staging for HCC. Having said that, yes, there will be a significant percentage of HCC will not be a bit. If they are a bit, it is useful for a long-term follow-up. So to that extent, it is useful. Otherwise, from a diagnostic point of view, it may not have much role.
These are the pore placement. Probably the surgical audience will find it interesting. Medical people. Okay, thank you. So this is, I'll run through the video because the main purpose is not to show the video or the technical aspect, but to discuss about the post-operative events and the histopathology. So here we can see a fairly large tumor mobilizing the left lobe of the liver, left lateral segment here. You can see the tumor here. So first we can see the inflow. For the non-surgical audience, caudate lobe has direct branches mainly from left portal venous system, sometimes from right, but it drains majority of the time drains into the IVC directly with the multiple branches, one or few branches. So we use rubber retraction technique. Here you can see if we are dissecting the caudate lobe from the IVC. It's a prehepatic segment. So carefully we have to dissect all the inflow as well as the outflow. This is the outflow, as you can see. We tackle the inflow here on the right border or the left border of the hepatoduodenal ligament. We use CUSA to dissect it, divide the little bit of parenchyma, and then we tackle both the inflow as well as the outflow. So whichever that comes to our view first we do. Generally we try to do, do the outflow, inflow control first. So slowly we make our way into the transection, separating the caudate lobe from the caudate process. We use the various energy sources, including the ligature. You can see the ligature clips CUSA. So here it requires a lot of patience for the surgical crowd, I say. You can see the ICG being given, and we can see, this is the portion where it has still a little bit of inflow, meaning the portal blood flow is still there. By that we can assess how far we have to go with regards to the inflow control. So it's called negative staining with ICG. We all thought it to be HCG. This is the ICG at the end of, almost at the end of the procedure. We are just in the final bit. These are called image guided surgeries, which really help us in navigation during the surgery. May not be of much use here, but in segments, other segments like segment 2 and 3 and others like other segments, it has got a lot of oncological value in the sense we can go exactly bang on the segment. We will not remove more or less. So this is about the surgery. Patient was discharged on 4th post-operative day. She has got a fairly uneventful recovery. And to our surprise, histopathology showed a well-differentiated neuroendocrine tumor. Then we to our surprise, this was like this. Then we retrospectively, in the sense, we did all the other markers for the neuroendocrine tumors, and then when we did the serum chromogranin, it was high, it was elevated. In the hindsight, but we never, generally we don't do a chromogranin for all SOL liver. So then we plan for a Dotonac PET. This was the immunohistochemistry, and you can see synaptophysin positive, chromogranin A diffuse positive. Fortunately, Ka67 index is low. So we have got a well-differentiated grade 1 neuroendocrine tumor It's all the positive markers for chromogranin. And the patient had daughter neck in the post-operative period, had a lesion about less than a centimeter in the distal body of pancreas, active porta nodes anterior to main portal vein. These are the parathyroids active, pituitary active, so suggestive of MEN1 syndrome. The patient underwent total thyroidectomy with thymectomy later for the MEN1 because of the parathyroids and the pituitary. Next, subsequently, daughter neck pit, you can see, these are the findings which was follow-up in the follow-up daughter neck pit, showed marginal increase in size of the enhancing lesion in the distal body of pancreas. So stable tiny lesions in the skull, probably these were insignificant. The significant things are portohepatis nodes, and in the distal body there is a sub-centimeter nodes. So any further any clarifications before we move on to the splenectomy?
Shankar?
Sir, Shankar sir?
No, we had an aggressive surgery just before you came. And
Basically, this is a well-differentiated tumor. And your DOTA scan showed multiple lesions in the porta hepatis and one in the tail of the pancreas.
Oh, no, not multiple, sir. No lymph node is there. There is a lymph node and one. We have got two foci of
That's a
lesion.
DOTA positive.
Positive, sir. DOTA positive. These are DOTA positive.
So I thought with this you can try, because it's a well-differentiated, you can try PRRT and then see how the lesion is going to.
Yes, sir. We also thought in the same line, but it's a stable disease, amenable for surgery. Why can't we remove and then try to give?
Because the pancreatic lesion is less than a centimeter.
Yeah.
And now the literature says that a sub-centimeter neuroendocrine tumor can be safely observed.
Follow up, yes.
Anything more than 2 centimeters, definite surgery. 1 to 2 centimeters is a gray area. So,
Senthil, we have seen from Sharan's discussion earlier that the knife is the only weapon we have. Anything we see, we think of surgery. I mean, that's how.
Sir.
Huh? No, you're already sitting far away from me. But yeah, Hari, you have a comment to make on this?
This is one area where in the stable disease, even fortunately some of the malignancies or tumors, we still tackle. One such tumor is, one such area is neuroendocrine. Rest are all by and large have been taken over by the medical oncologist and the radiation oncologist. See, having said that, this is a stable disease. We can aim for cure. Re-surgery is possible. Yes, Gautam?
So, just one thing, like if retrospectively thinking, then the liver is actually a metastatic disease.
Node was not seen before.
Yes, there is
Node was not seen before.
not seen before. This is the second DOTA pit. The first DOTA pit, after the surgery, didn't pick up the node. It was only a pancreatic lesion. Subsequently, on follow-up, found to have a node. Very small, of course, we still see that one, a very small sub-centimeter pancreas, that too well-differentiated one, having a metastasis of about 5 centimeters in the caudate lobe. Possible, but unlikely. So, I mean, tumor in PNET, nothing can fall under the tenets of our...
I disagree with this point because quite often we see very small pancreatic lesions but very big liver secondaries. No, I mean that's the most likely thing, that the primary is. I don't know how often you get a primary neuroendocrine in the liver, then you find, just
Yes,
like
sir.
what.
Logic-wise, yes, PNETs are common and metastasis is common. Against this, grade 1, well-differentiated, like Ki67 is 1%. So and obviously, we don't have any, way we could have found out before histopathology, because everything was washout is there. Even there were, Shankar sir was telling why you did PET CT or PET, MR, when the diagnosis is so obvious. So it's basically a surprise. A surprise post-operatively, we landed up in neuroendocrine. Then all sorts of workup started. So, and then multiple surgeries, yes, please.
The setting of men 1, like now that we identified something in the pancreas, we know that usually the outcomes are much worse. I mean, they are likely to be, I mean, is it any worse in men 1? Like if you find a pancreatic lesion, a resection in a non-men pancreatic neuroendocrine tumor versus resection in the setting of men 1?
Yes, we
How are
try
the
to
outcomes?
delay the pancreatic neuroendocrine, PNETs, till we settle the other piece, pituitaries and the parathyroids. So once that is settled, we have the biochemical remission, then we'll go for the PNET. So that is how we followed. That's why the patient you see, patient underwent total thyroidectomy before we ventured into laparoscopic.
How are the outcomes? Like, I mean, generally, in compared to a non-men peanut resection?
Peanut, yes.
Are
The
there
outcomes to be the same.
Metastasis-wise or recurrence-wise, is there any
Metastasis-wise,
worse?
probably a little bit more. But the outcomes, by and large, in a grade to grade, it's the same.
So
We
that-
don't see any difference grade to grade.
I think in the guidelines also, as Sir was saying, generally less subcentimetric we wait and watch, but one exception is men 1. Because generally they
Yes,
are
correct.
likely to be more aggressive. So the
Yeah, chance of Mets is more, slightly
so-
more. In men 1 associated
they are
nets,
more
peanut.
aggressive.
So if such is a setting, then is surgery required or should we go for radionuclide therapy? Like when we know
See,
that the risk of
okay,
Mets is higher.
that's a point to ponder. If it is resectable, then we can go for resecting. And it's a grade 1 slow growing innocuous tumor. We can always tackle it surgically. If it's multiple tumors where we see 2, 3 foci of lesions in liver with multiple liver, peripancreatic or hepatoduodenal lymph nodes, then probably that's going out of our hands as from the surgeon's point of view. The disease is restricted when we can able to try to have removal. Of course, in an oligometastatic situation, we can go and then resect it as much as possible. So,
Just before you
Yes, sir.
proceed, I don't know how much medical audience will appreciate doing an isolated caudate lobectomy in open surgery itself is it's a very difficult surgery. Doing a laparoscopy is, I think we have to congratulate you for doing that.
thank you, sir. It's more of a finite work in a limited area. We have to go with, sir? Yes, exactly, sir. It requires perseverance and very, minute movements we need to have. All are confined to one space, so one area. I agree, sir, it's a challenge, but we need to go systematically. So this one was, the histopathology was again a well-differentiated net with the margins free, lymph nodes again, no lymphovascular invasion, mitosis. Again, it shows almost the same pattern as the caudate lobe. Post-operatively, the patient had uneven full recurrence. And 1 year follow-up, she is under close follow-up, there is no recurrence. So basically, we did the re-resection is also possible. Probably a laparoscopy had aided in having an uneven full recovery for the 2 caudate lobe as well as the distal pancreas, distal pancreatectomy. Spleen preserving distal pancreatectomy. This is about, I skipped this because Shankar sir already alluded to. We have technical difficulty in, reaching out to the caudate lobe. I'll just skip this one because we have mixed audience. So this is what basically we did, left side approach. This everyone can understand. These are, basically we have to go from here between the caudate process and the caudate lobe, so that we have to divide at this point. At the same time, identify all the branches that's draining into the IVC, so that we don't have any injury to the major vessels surrounding the caudate lobe. So this is about the first case, or probably I can stop with this one if for the want of time. So this particular case, as said, surprises post-operatively is possible. And even after our tumor board discussions, we were at a loss to find out in what way we could have done better in identifying that one, whether an endoscopy would have helped, because on a routine workup for HCC, serum chromogranin doesn't fall into any of our protocol. So it missed all our, and sub-centimeter pancreatic tumor would have been there. It was missed in a conventional CT during our routine workup. So that's what it was. Yes, a tail of pancreas peanut with metastasis to the caudate lobe. Thank you very much, and any questions and comments, welcome.
What was the chromogranin before the pancreatectomy, sir? Did it?
Oh yes, that was it didn't come to normal. It reduced. It was about 300 to 400. After that, it came to normal. Yes. So any comments? Somebody would, what are the other
Bhaskaran, any
management
comments?
options?
But I think quite an interesting.
Senthil, how do you like to follow this patient?
Yes, sir. Yearly Dotonac, probably 6 monthly serum chromogranin. If there is a 6 month, when the chromogranin starts rising, probably we can decrease the frequency, increase the frequency of Dotonac PET. That's the only, modality by which we can pick up early lesions. So serum chromogranin often, and supplement with Dotonac when there is a doubt. That's what we do.
Doctor, now if
Yes, sir.
suppose you had seen that, that splenic, the pancreatic lesion, the tail of the pancreas, had you seen on the first itself, along with the caudate lobe, would you have changed any management, or will it still be the same?
Then yes, I will have a thought, because we are having a pancreatic lesion with a caudate lobe lesion. Caudate lobe, secondary, caudate lobe secondary. So Dotonac definitely would have picked up a lesion here and there. At this point, if it's very avid, like Dotonac avid lesion, I will also would have given a thought of PRRT, because we are dealing with a metastasis, and possibly we can try and do a biopsy. If the Ka67 is low, then probably I would have done the same thing, combining distal pancreatectomy with the caudate lobe resection. High PRRT, high Ka67 index, the chance of recurrence is more. Then probably if it's say grade 2, obviously grade 2 and 3, I would have definitely thought about PRRT. Grade 1, in the hindsight, I would also probably done the same thing. Probably I would have combined a distal pancreatectomy with a caudate lobe resection.
But I think if the whole body was done, you would have suspected men one, sir.
Yeah.
If men one would have come again, the
Yes,
management would have changed.
Changed, correct, that's right.
But you think that pancreas is the primary and the caudate lobe was the secondary?
Yes. In the hindsight, yes, that should be the
But
problem.
did you check that out? Did you check the morphology?
No way we can find out, sir. It's difficult, very difficult to find out.
if you compare-
But yes, it's both are grades, the same grade. Both grade 1, the K67 index is the same. So we were made to believe that unlikely to be too primary, so it should be from pancreas to the liver.
Yeah, that's logical, Hari, that's what it is. And of course, the follow-up, there are chances that the liver may get some more lesions in due course of time.
Yes, yeah.
And if you get them, you would again, may not think of a surgical intervention. I think that's quite an interesting
Yes,
case.
definitely. This is actually a fourth surgery when you come in thyroidectomy in parathyroids. It's a fourth surgery if you want to contemplate. Probably a single lesion avoidable. Still, as a surgeon, I will try. Gautam, you are laughing. What do you do? Yes. As a surgical mindset. Again, this is a forum where surgeons and the medical gastroenterologists meet. Probably you can also have the other perspective. If it is a single lesion, especially in the pancreas, then or peripherally situated liver, still we can try the third resection.
Probably remember, lanreotide, wait, see whether biologically stable.
Yes. Yeah.
Thank you, Senthil. Thank you so much.
Thank you so much, sir. you.